Namaste Vidya, Anisha Kushaw Vidya. A very good morning to you all. Myself, JV and Dr. Ravi Jain, Assistant Professor, Department of Practice of Medicine, and Faculty of Homeopathic Science at JAYOTI VIDYAPEETH Women's University, Jaipur. In today's lecture, we are going to discuss about nephro. In the last lecture, we have discussed about nephrolithiasis, and in today's lecture, we are going to discuss about polycystic kidney disease. In this series, we have been discussing about the diseases of the urogenital system. Until date, we have discussed about various diseases like acute renal failure, we have discussed about chronic renal failure, common diseases like UTI. We have also discussed about the nephrotic syndrome and nephrolithiasis in the past. Today, we are going to discuss about yet another important disease, that is polycystic kidney disease. In today's lecture, we are going to discuss about the different aspects of polycystic kidney disease in terms of etiopathogenesis, clinical features, investigations, and management of the same. So, what is polycystic kidney disease? As the name suggests, there are multiple cysts that are formed in the kidneys. So, polycystic kidney disease is basically a disease that is group of genetically heterogeneous disorders that is a leading cause of kidney failure. Kidney failure we have already discussed earlier, and polycystic kidney disease is one of the important cause, and it is a genetically heterogeneous disorder and a leading cause for kidney failure. There are three types of chronic kidney disease, which includes autosomal dominant polycystic kidney disease, and we have autosomal recessive polycystic kidney disease, and acquired cystic kidney disease. So there are three varieties of polycystic kidney disease. Number one is autosomal dominant, the second one is autosomal recessive, and the third is the acquired cystic disease. The autosomal dominant form of polycystic kidney disease, it is the most common life-threatening monogenic disease. So autosomal dominant form of polycystic kidney disease, it is the most common and the life-threatening monogenic disease. Autosomal recessive form of polycystic kidney disease, it is rarer, but it affects usually the pediatric population. So autosomal dominant form of polycystic kidney disease is the most common life-threatening disease. Autosomal recessive, it is rarer, but it affects the pediatric population. Acquired cystic kidney disease, it develops in association with the long-term kidney problems. So if we are talking about the acquired cystic kidney disease, it is developing as a result of long-term kidney problems, especially in the patients who have kidney failure or who have been on dialysis for a longer time. So acquired cystic kidney disease, it develops in association with the long-term kidney problems, and especially in the patients who have kidney failures and who have been on dialysis for a long period of time. Kidney disease, chronic kidney disease is characterized. Acquired cystic kidney disease is characterized by progressive form of epithelial lined cyst in the kidney. So there is progressive formation of the epithelial lined cyst in the kidneys. And there is enormous growth of these cysts that ultimately lead to the normal surrounding tissues and loss of renal functions. So there is a loss of normal surrounding tissues and loss of the normal renal functions. That is the normal kidney function. The cellular defects that we are going to see here are increased cell proliferation and fluid secretion. So there is increased cell proliferation and the fluid secretion. There is decreased cell differentiation. So we will have increased cell proliferation and fluid secretion. Next, we will have decreased cell differentiation and abnormal extracellular matrix formation. So the different type of cellular defects that we are going to see in case of chronic kidney disease, polycystic kidney disease, is increased cell proliferation and fluid secretion. There will be decreased cell differentiation and abnormal extracellular matrix formation. Now we come to the pathogenesis of the chronic kidney disease. What are the different steps? What is the different pathophysiology that is involved in the development of chronic kidney disease? Chronic polycystic kidney disease. It is characterized by progressive formation of epithelial lined cysts in the kidneys. So there are different epithelial lined cysts are formed in the kidneys, and the enormous growth of these cysts ultimately leads to loss of normal surrounding tissue and loss of renal function. So multiple cysts are formed in the kidneys, which are leading to the loss of normal surrounding tissue and also the loss of renal function. There are different types of cellular defects, which includes increased cell proliferation and fluid secretion. So we have increased cell proliferation and fluid secretion. There is decreased cell differentiation and an abnormal extracellular matrix. So the cellular defect includes increased cell proliferation and fluid secretion. There is decreased cell differentiation and abnormal cellular matrix. Now the clinical manifestation, clinical signs and symptoms with which the patient of chronic kidney disease is coming to us. Autosomal dominant chronic kidney disease is characterized by progressive bilateral formation of renal cyst. So there is bilateral formation of the renal cyst in the kidneys, and hundreds and thousands of cysts are usually present in the kidneys. So we have a lot of cysts in the kidneys, hundreds and thousands of cysts are formed in the kidneys of the patients, most patients in the 5th decade. There is enlarged kidneys, and it can reach 4-fold increase in length and weight up to 20 times the normal weight. So the increase in the kidney can become 4 times increased, and the weight can increase up to 20 times. So size can increase 4 times and weight can increase up to 20 times the normal weight. The clinical presentation is highly variable. So the clinical presentation of this particular ADPKD is highly variable. Many patients are asymptomatic until the 4th and 5th decade of life. So many patients are asymptomatic till the 4th and 5th decade of the life, and it is diagnosed by incidental discoveries of we have hypertension, abnormal masses, black and flank pain in around 60% of the patients. The pain results from renal cyst infection, hemorrhage, and nephrolithiasis, and gross hematuria resulting from the cyst rupture occurring in 40% of the patients with recurrent episodes. So the clinical presentation is highly variable, and many patients are asymptomatic until the 4th and 5th decade of life. It is diagnosed by incidental discoveries of hypertension. There is abdominal masses with black or flank pain in 60% of the patient. The pain results from renal cyst formation, hemorrhage, and nephrolithiasis. There is gross hematuria. The patient may complain of gross hematuria and resulting from the cyst rupture in around 40% of the patient with recurrent episodes. There can be flank pain and hematuria which can coexist if the cyst ruptures is connected with the collecting system. So flank pain and hematuria. Proteinuria is a minor feature that you can see in this disease. Infection is the second most cause of death in the patients with ADPKD. Cardiovascular complications are the major cause for mortality in the patients with ADPKD. The infected cyst and the acute pyelonephritis are the most common renal infection that are associated with fever, flank pain, and without bacteria. I will again repeat the clinical features. ADPKD is characterized by progressive bilateral formation of the renal cyst. Hundreds to thousands cysts are formed, and large kidneys can increase 4 times in length and up to 20 times the normal weight. The clinical presentations are highly variable, and many patients are asymptomatic until the 4th and 5th decade of their life. It is diagnosed by incidental discoveries of hypertension, abdominal masses, black or flank pain in around 60% of the patient. Pain results from the renal cyst infection, hemorrhage, and nephrolithiasis. And there is gross hematuria resulting from cyst rupture in 40% patients with recurrent episodes. There is flank pain and hematuria that coexist if the cyst that ruptures is connected with the collecting system. There is proteinuria that is a minor feature. Infection is the second most common cause of death for patients with ADPKD. An infected cyst and acute pyelonephritis are the most common renal infections that are associated with fever, flank pain, without hematuria. Next, we come to the complications. The complications and renal insufficiency often correlate with the structural abnormality of the renal parenchyma. So there is abnormality of the renal parenchyma. There is complication and renal insufficiency that often correlate with it. The kidney stones, it occurs in around 20% of the patient. This is a complication. In more than half of the stones in the patient with ADPKD are composed of uric acid, and the remainder are due to calcium oxalate. So 50% of the patient will develop nephrolithiasis, and most stones are composed of uric acid and remainder of calcium oxalate. Hypertension is a common and typically occurs before any reduction in the glomerular filtration rate. Hypertension is a risk factor for both cardiovascular and kidney diseases. Intracranial aneurysm occurs around 4 to 5 times more frequently due to the defects in the atrial smooth muscle cells. And myofibroblast causes high mortality. Liver cysts are derived from the bilateral epithelia, are most common extrarenal complications. Now, how to diagnose a case? Whenever a case is coming to us of the polycystic kidney disease, how to diagnose such case? Early diagnosis of ADPKD, autosomal dominant polycystic kidney disease. Hypertension is present in such patients with gross hematuria due to rupture of the cyst. Multiple pregnancies are seen. These are at-risk factors. Large kidney size, and the disease can present early in utero, but end-stage renal disease typically occurs in middle age. So, risk factor has an early diagnosis of ADPKD. If it is occurring early in life, that means the patient is at risk factor. If there is hypertension, if there is gross hematuria, if there are multiple pregnancies, large kidney size, and this disease can present in utero, but end-stage renal disease typically occurs in the middle age. Now, how to diagnose a case of polycystic kidney disease? Whenever a case of polycystic kidney disease is coming to us, how can we diagnose such case? Diagnosis is done by, number one, a positive family history. A patient with a positive family history has a definitive diagnosis of such case. Renal ultrasonography for the presence of renal cyst. CT scan and T2 weighted MRI scan with or without contrast enhancement are more sensitive. So we have polycystic family history, we have renal ultrasonography for presence of small renal cyst, CT scan and T2 weighted MRI, genetic testing by linkage analysis and mutational analysis. Now, how to manage a case of polycystic kidney disease? No specific treatment is there to prevent the cystic growth and decline of the renal function. So if there is cystic growth and decline in the renal function, we cannot stop it or do nothing to prevent it. Blood pressure control should be our target below 140 by 90 mm of Hg. The treatment of the kidney stones if it is present. Analgesics for painkillers are given for pain relief and hydration to ensure adequate urine flow. Surgical decompression of the cyst can be done. More than half of the ADPKD patient eventually require peritoneal dialysis, hemodialysis, or kidney transplant because of the non-functioning kidney. Large polycystic kidneys and recurrent renal cyst infection may require pre-transplant nephrotomy and bilateral nephrectomy. Specific treatment strategies. So specific treatment strategies for ADPKD are focused on slowing renal diseases progression or lowering cardiovascular risk. So in the management, there is no specific treatment for prevention of cystic growth. Blood pressure control has to be done below 140 by 90. Treatment for the kidney stones, analgesics for pain relief and hydration, surgical decompression of the cyst. More than half of the ADPKD patient eventually require peritoneal dialysis. Large polycystic kidneys and recurrent renal cyst infection may require pre-transplant nephrectomy and bilateral nephrectomy. And specific treatment strategies for ADPKD have been focused on slowing renal disease progression and lowering cardiovascular risk. There are various homeopathic medicines which could be prescribed in such case. A few of them are: number one, aconite. Aconite is given in the incipient stage of post-scarlatina nephritis, pain in the loins, scanty urine without blood. Apis mellifera for the edematous swelling of the face and extremities, with paleness, ascites, edema, pains in the hand, back, and limbs. Apocyinum cannabinum with palliative and dropsical conditions where the urine is scanty. It is also useful for coma and convulsions in nephritis of pregnancy. Belladonna has a greatest service in inflammatory of the kidneys with perceiving burning pains in the lumbar region. Cantharis, we have nephritis with cutting pains in the lumbar region. The urine is passed in drops and is mixed with blood with much urging. Convallaria, which has nephritis from the heart disorders. Glonoine, which has albanous urine and useful in acute and hemorrhagic nephritis. And plumbum, that is granular degeneration of the kidneys. So this was all about polycystic kidney disease. Now it's your homework to go through the book and you have to write the answer of the question which I have given you in the e-notes. That is, define polycystic kidney disease, write the different type of stones, give their classification, clinical features, investigations, management from the Davidson book. So you have to write everything about polycystic kidney disease. Its etiopathogenesis, clinical features, investigations, and management. So this was all for today. In the next lecture, we will be discussing about BPH or the benign prostatic hyperplasia. So this session is powered by digital version 2.0 JAYOTI VIDYAPEETH University. I hope the session is clear to you. If you have any query, please mention in the comment box and I'll try to resolve it. So this was all for today. Thank you very much. Have a good day.